Good morning, class. It's Professor Myria Evans. Today is a Thursday, I believe April 16th. Yes, April 16th. This lecture is on peripheral nervous system part 2. This happens to be the spinal nerves. We have finished peripheral nervous system number 1, which was the cranial nerves. And that information was on the previous exam, and now we're on our new exam material, our last exam material, where we will cover the peripheral nervous system, cranial nerves, then we'll go on to autonomic nervous system, and then we'll do the special senses, which will be the end of the class. All right, so peripheral nervous system. When we talk about the peripheral nervous system, as you recall, it's the pathways to and from the brain and the spinal cord. Pathway to and from the brain and are going to be referring to the cranial nerves, and then the pathway to and from the spinal cord would be referring to the spinal nerves. There are 31 pairs of spinal nerves, therefore there are 62 total because they run on both sides. If you recall in our material from central nervous system part 4, where we were talking about the spinal cord itself, we know that we had dorsal horns and we know that we had the ventral horns. We know that the dorsal horns were for sensory and the visceral horns were for motor. And the way that the spinal nerves work is that they come off of those horns into rootlets and they become a root, which means that all spinal nerves are mixed nerves. All spinal nerves have a motor as well as a sensory part to them. So they're all mixed. That's what I said already. Okay, so when we look at the way that they've broken down the nerves, 8 pairs of cervical nerve, 12 pairs of thoracic, 5 pair of lumbar, 5 pair of sacral, and then 1 tiny little coccygeal. So, you know, your coccyx, of course, is your tailbone. Anyway, this is what it looks like. Again, remember, we're spinal cord, right? Coming off the spinal cord. And remember, of course, that we have the cauda equina, which is the horse's tail, right? So the terminal end of the spinal cord resembles a horse's tail, hence the name cauda, which is tail, equina, horse, like, you know, equestrian. All right. So again, I've already told you that dorsal was going to be sensory and ventral would be motor. And so we have the two roots that come together. And so they come off of the spinal cord in rootlets, and then they make the spinal cord. So roots, rootlets, spinal cord. So here are the rootlets here, and then the roots. And so when you look at them, each one of them, of course, would be a mixed nerve, as I mentioned before. So the difference between what you have to know for the spinal nerves compared to what you had to know for cranial nerves is that the cranial nerves, I told you had to know the Roman numerals 1 through 12. You had to know their names and you had to know their functions. For the spinal nerves, this is the most important part, and please take note of this. Listen to this recording as many times as possible so that you can understand what I'm trying to emphasize here. Because there are 31 pairs, and because there is an overlap in the numbers that are associated with them, because they have branches, and we have put them in plexuses. So what you have to know for the spinal nerves is, if I give you a spinal nerve by name, and because you know your terminology, you should be able to put it in the appropriate plexus. There is a cervical plexus, there is a brachial plexus, there is a lumbar plexus, and there is a sacral plexus. Now, if you think about the regions of your body, cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. So for sacral, I always want you to think of the backside, right? So remember the sacrum, 5 fused vertebrae, and they, of course, is what brought our pelvic girdle together. So we have the sacrum there and the 2 os coxae. So the sacrum's the backside. For lumbar, I want you to think of the things that are in your, anal genital area. So think of your upper medial thigh, and think of below your stomach. For example, if something is hypogastric, it means it's below the stomach. Well, that's the area below the stomach. If something is genital femoral, so genital area and then femur like thigh, that would be that area. Now, the reason why I say that is because once I give you the names of the spinal nerves, you should be able to determine what plexus they belong to, again, because you know your terminology and you know your body parts using the correct scientific medical terminology. So let's see. I'm going to give you a nerve that is a spinal nerve, and you are going to tell me in your head, of course, because I can't hear any of you, but you're going to tell me where you think this spinal nerve belongs, and you're going to tell me why, right? So you're going to think that through. So there's a spinal nerve called ansa cervicalis. That one's really easy. Ansa cervicalis. Of your four options, cervical, brachial, lumbar, and sacral, which one do you think ansa cervicalis belongs? So of course you, I hope, selected cervical. Yay, and you'd be right. If not, rethink it. So now I'll mention another one. Unless you're thinking cervix, like the female cervix, and then you thought it was going to belong to lumbar. Common mistake, but ansa cervicalis, so cervical. And I'll give you another one. And I want you again to think about it. So we have cervical, brachial, lumbar, and sacral. And this one is the ulnar nerve. I'll give you a second to think about it. So what you're thinking in your head right now is, well, ulna, that's one of the bones in my arm. Brachial means arm. So ulnar probably belongs to the brachial plexus. And guess what? Ding, 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 ding. You are correct. Now, with that being said, there are some that you are just going to have to know. So I could go on and tell you that within the brachial plexus, that there's an ulnar nerve, there's a median nerve. You wouldn't know medium for that one. But there's an ulnar nerve, there's a radial nerve, right? That one you would probably get. The median is the one that's, in between the two of those. There is also, pectoral, so like supra. Oh, I know one. Ooh, here, ready? I'm going to give you the name of this spinal nerve, and then you tell me where it belongs. You have to think about this one, though. Supraclavicular. The supraclavicular spinal nerve. Where does it belong as far as plexuses? Cervical plexus, brachial plexus, lumbar plexus, or sacrum? Supraclavicular. Well, if you thought of super like superior and clavicular like your clavicles, and you went, hey, above my clavicles is my neck, that would be cervical, and you would be right. All right, anyway, that's what I'm telling you, is that on the exam, a sample question would read, all of the following belong to the brachial plexus except, and then I would list some of the spinal nerves, and then you'd have to tell me which one you thought didn't belong. Again, just thinking of the names. I will tell you that the phrenic nerve, which innervates the diaphragm, and the diaphragm is the muscle that helps us breathe. That one is in the cervical plexus, and you just have to remember that because the diaphragm is way down here. Cervical plexus is up here, innervates the diaphragm, and phrenic nerve, you just are going to have to know that one. Sciatic nerve, some of you guys may be familiar with that one because the sciatic nerve, a lot of people like, I have sciatica. And so the sciatic nerve would, if it's been damaged or pinched or some type of injury to it, then you have this pain that radiates from the back of your thigh all the way down. And that's because the sciatic nerve is the thickest and the longest nerve in our body. It's actually two nerves together. It's the common fibular and tibial nerve together, and we'll talk about that again. And then of course fibula, like the leg bone, and fibularis like the leg muscle, and then tibia like the leg bone, and tibialis anterior like the muscle. So obviously that is a nerve, sciatic nerve. So tibial and fibular nerves that would innervate, of course, the muscles in your leg. All right, so let's see. So there are the plexuses that I mentioned before. And I also want you to know that there is an area in the body, a region of the body that there's still innervation and there's still muscles that takes place there, but there's no plexus. There's no thoracic plexus. That should have been kind of, I hope, evident or obvious to you when I was going over them. I just skipped this huge region mostly where our internal organs are. But we'll talk about how and why there's no plexus there. So if you think about the muscles that are there, we do have our intercostal muscles, and those are the muscles that are in between our ribs. And then we have some back muscles, very thin, but we do have some back muscles that are there as well. And then we have our internal organs. Internal organs are already innervated by the vagus nerve, which is cranial nerve number 10, if you recall. All right, so down here, because we're in that thoracic region, just to let you know, so it says the rami communicants contain autonomic nerve fibers that join the ventral rami in the thoracic region. So again, the viscera that are there. Meningeal branch, of course, the vertebrate meninges, remember the coverings, dura mater, pia mater, arachnoid mater. Arachnoid mater is the one that looked like a spider web. The pia mater was directly attached to the brain and the spinal cord, and the dura mater was the most superficial and durable, right? So the hard covering of the meninges. Okay, so this is a picture of the ramus. So if you look here, we have the dorsal ramus or rami, right? These are back muscles, of course. And then if you look here, these are the intercostals. So I'm taking the arrow and I'm aligning the intercostals, which would be the muscles between the ribs. Now, the reason why I'm emphasizing that there's muscles here is because, as you guys know, the effectors, right, of the nervous system are always going to be skeletal muscle, smooth muscle, cardiac muscle, and glands. Skeletal muscle requires nerve stimulation, and so we are referring to the nerves, right, of the spinal cord that go to the effectors, so spinal nerves. All right, so let's see. So we have the regions, and I said before, so we have cervical, brachial, lumbar, and sacral plexuses. Notice that there are not a plexus that's assigned to the thoracic region. Doesn't mean there aren't things to be innervated there. It's just there's no plexus there. And then it says the plexus has fibers that crisscross, and so they go to different, they serve several different spinal nerves. This is one of the reasons why you'll never have to tell me, which numbers are going to be included in which plexus. And that's because there's going to be overlap, for example, and I'll show you that in just a minute in a picture. Anyway, the fibers from the ventral ramus go to the body periphery, and there's several routes again because they branch. This is helpful for us that there's branches. So several spinal nerves like branch into additional spinal nerves, which means that when you have damage to one nerve, it's not going to cause complete paralysis of the muscle that is innervating. So it's a protective thing, and it's helpful. All right, so the cervical plexus is the plexus of the neck area, right? So cervical. And it says here that it innervates the skin of the neck and the ears and the back of the head and the shoulders, and of course branches off into neck muscles. So the phrenic nerve is the one that I told you you're just going to have to know that belongs to this plexus. It innervates the diaphragm, and you are going to have to know that because, again, it's like the exception to this plexus. And so when you look at the phrenic nerve, you're just going to have to remember phrenic nerve belongs to the cervical plexus, and it innervates the diaphragm. So here are the pictures. Now, I mentioned the ansa cervicalis. This is the one that I mentioned, ansa cervicalis, and I mentioned it because cervical was in its name. But look at the other ones that should also help you. You already know that the occipital bone is the skull bone that's in the back. You know that the occipital lobe is the lobe of the cerebrum that's in the back. And so now we're at the back, right, of the head, and we have a lesser occipital nerve and we have a greater auricular nerve. Your auricle is your ear, and so we're at the back of the ear, and of course that's going to be near this neck region, and so these belong to the cervical plexus. Now remember on the exam what I said, you are not going to have to know their names and their functions. You'll have to know when you see their names which plexus they belong to. And all that means is that when I say ansa cervicalis, you say cervical, and you think that makes sense and put it in the cervical one. Phrenic is the one you're just going to have to know. There's supraclavicular, and I mentioned that one as well. So supra like superior. So these are my clavicle bones here, and supraclavicular would be above the clavicle. So superior to the clavicles. That's my neck region. Lesser occipital is there, greater auricle is there. Oh, and transverse cervical nerve. It's again in the name. So that's what you're going to have to know for the spinal nerves. Okay. Now, because the phrenic nerve is there and it innervates the diaphragm, and a diaphragm is necessary for breathing, it tells you that if both phrenic nerves are severed, the spinal cord, that region of the spinal cord is destroyed, or where the phrenic nerve would be, the person becomes paralyzed in the diaphragm, and the diaphragm helps you breathe, and so you die. So respiratory arrest occurs, and you'll have to be on a mechanical respirator to stay alive. So I just let you out, so you need to go sit down. Go sit down. That's the rat talking to me. Everybody else is behaving right now. I just let you out, Hercules. Come here. Come here. Come. Anyway, so the brachial plexus, of course, brachial means arm, and there are 5 roots and 3 trunks and 2 divisions and then 3 cords that are associated with the brachial plexus. Now you see the numbers up there where they tell you C5 through C8, and then T1, and then often there's also C4, which would be before C5, and could go down to T2. That's what I mean by you don't have to know, excuse me, the exact numbers that are associated with these plexuses, because there's overlap. Remember, one branches into the other, branches into the other, branches into the other. So here, and they're color coded here, right here, where I'm using the arrows. See, these are the blue ones. So these are the roots, and there are 5 roots that are there. And then notice how it says they sometimes could include C4, but basically it's C5, C6, C7, C8, and then this T1, but could include, right, C4. Then we have, is that what they said, C4? Yeah, C5 through C8 and T1. Okay, sorry. And then if you look here, we have the trunks, and those are the 3 trunks. Then we have the 2 divisions, an anterior and posterior. He's going to keep doing that. I'm so sorry. I'm going to have to lay him out. Anterior and posterior. And then we have the 3 cords, which are lateral, posterior, and medial. So you don't have to know each of those for me. Just know the complexity of that brachial plexus, because it comes down the arm and it's going to innervate, of course, several different things. So if you look at where this is, right? So you think of your pectoral muscles, right, that are here. And then you think about your deltoids, so your shoulder muscles that are here, muscles that are in your forearms, so biceps and triceps. And then, muscles that are in your upper arm, biceps and triceps. And then muscles that are in your forearm, which we have, of course, our extensors and flexors, et cetera, et cetera. So look at the names of the nerves. So we have axillary, and I know you guys recall that that's under your underarm. And then we have radial, which is one that I mentioned already. We have the ulnar that's there. I mentioned that one as well. We have the median that's there. We also have a medial pectoral, a lateral pectoral, an upper subscapular, a lower subscapular. So you know your terms. So your subscapularis is on, as you guys know, is the muscle that's on the back that fits into the subscapular fossa of the scapula. So since you know your names of your bones and you know the names of your muscles, hearing the names of the nerves should make it really easy to put it in the corresponding plexus. So what else is there for that one? Axillary, radial, ulnar, median, pectoral, scapular, right? So you should be able to put those in that plexus. All right. Now they go through and they tell you what each of these spinal nerves innervates, like what muscle. So see how it says axillary? Of course, we know it's the armpit. It does tell you, and again, names that you know, innervates the deltoid, so your shoulder muscle. Tres minor is also there, and then the skin and joint capsule of the shoulder in general. You don't have to know this for me. I am not going to ask you which spinal nerve innervates which muscle. I'm telling you that when I give you the name of a spinal nerve, you should be able to put it in its correct plexus. Anyway, so they go on and tell you which each of those do. So the median is, most of the flexors. So remember in the forearm, pronators, the wrist, fingertips, flexors, right? And just again, if you recall from having gone through the lab material that I've given you, the videos that I gave you on dissection, when you look at the flexors versus the extensors, extensor muscles are going to be like on the outside, right? So external extensor, and the flexor muscles are going to be on the inside. So when we named the muscles here, like in the cat, we have the palmaris longus, right? That runs, into the palm. And then you had a, ready, flexor carpi radialis on the side of the thumb. And then you had a flexor carpi ulnaris, which is on the ulnar side. So if I hold my hand up like this, and you know that the radius is aligning with the thumb, and you remember the ulna aligns with the pinky, holding the palm up like this makes it easy for you to know that this would be radialis and this would be ulnaris. Okay, so when you look at these, and again, these are all flexors on this side, and then when the cat was pronated, laying down this way, you saw on the outside that these were all extensors. So there's an extensor carpi radialis, an extensor carpi ulnaris, okay, and then a bunch of other extensor muscles. But I basically just telling you that we already know that nerves innervate muscles. You've already learned your muscle names, or you're learning your muscle names, and you know your bones. So this should be very easy just to take the name of a nerve and make sure it belongs to the right plexus. So there's the ulnar, and then of course the radio, and then they go on to mention, so this is that flexor carpi ulnaris that I was talking about a few minutes ago. This is flexor, and then the radio, these are the extensors, innervates is essentially all of the extensors. So extensors and flexors, again, this is just trying to help you make some connections with what you're learning in lab with the muscles. So in this picture here, they've, of course, highlighted the brachial plexus, how it comes, of course, off the spinal cord, and then runs. And this is kind of cool, right? So don't forget, we have the branches, or sorry, the roots, branches, roots, trunks. So we have the trunks that are here, and roots, then the trunks, which are in orange, and then the divisions that are there, and then the three cords. And then notice how they run all the way down. Now, one of the things I will tell you is that we do have an ulnar nerve. And when a person hits their funny bone, it's the ulnar nerve that causes you to get that tingling in like your pinky finger and numbness, and you try to shake it out. And they call it a funny bone. I don't know why. It is not at all funny when you strike it. People laugh, I think, to keep from crying. All right, so this is the brachial plexus, and it is dissected out of a cadaver. And I worked in cadaver labs, and these were pretty awesome to be able to dissect out the nerve plexuses that were in cadavers. I liked it. I like cadaver work. But anyways, you won't have to identify these on a cadaver. All right, so these are some damages to the brachial plexuses, the nerves that are within the brachial plexus. So it's very common when a person has, like someone yanks the person's arm really hard, that could happen, that could damage the brachial plexus and the nerves that are in there. When someone has a very forceful blow at the top of their shoulder, so think about the brachial plexus, again, coming off the spinal cord and then innervating in this area, you get this hard blow on the top of your shoulder, and you stretch or you pull those nerves, and sometimes, unfortunately, there's so much damage to them that you can't repair them. So upper limb, pull too hard, I said that already. A football player's arm is yanked, or yanks the arm of a running back there, and it could cause paralysis of that entire limb. Injury to that median nerve and make it difficult for you to have the pincer, so like the index finger and the thumb. So you would, have problems being able to pick up things with that. Carpal tunnel, you guys have probably heard of that. So back in the day when typewriters were hard and clunky, the way that the wrists were on the typewriters would do damage to the the nerves there. So carpal tunnel syndrome, and people would get surgeries, and people still do. And since we became aware of that, if you look at the way things are now, there's like these little pads that you can buy, nice soft gel-like pads that you can buy to rest your hands on if you're at a computer a long time or several hours during the day. They have them in each one of the lecture classrooms, as a matter of fact, a little soft pad there to try to, help with the carpal tunnel. Oh, you can also see this damage to the carpal tunnel or have carpal tunnel syndrome when the medium nerve is damaged by suicide attempts, so slashing it. All right, the ulnar nerve, said this one already, it's pretty vulnerable to injury because you would strike your funny bone on there. What else is there that they say? Oh, if you had damage to that, you'd have like a claw hand. So damage to that would give you the claw hand. This reminds me of the Scary Movie parody. It's my good hand, grab my good hand. The guy who was making the turkey. Yeah. Okay. Anyway, so striking the funny bone, again, is what we feel when we strike the ulnar nerve up against the medium epicondyle, and we get the tingling, like I mentioned, in the pinky finger. The radial nerve, it calls wrist drop. And so wrist drop is this, like your wrist is dropped like this. The inability to extend the hand. So remember, we have the extensors on the backside here, and we have the flexors here. So the inability to extend the hand, so you'd have wrist drop. All right, so now we are moving on, and I do apologize because I don't have a big thing that says that this is the lumbar plexus, but just looking at the names of the nerves here. So iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous, obturator, like the obturator foramen, and then femoral would help you, I think, maybe realize that this belonged in the lumbar plexus, because I told you that the lumbar plexus was like this anal genital area and medial thigh. So ilio, like your ilium, right, your hip, and then hypo, below gastric. So like at the hip region and below the stomach, iliohypogastric. Ilio inguinal. So right, inguinal is your growings. And so when you have your growing area, and then of course ilio hip, and then genital, right, femoral. So femoral thigh, genital, and those are ones that I mentioned already. Remember the os coxa, so the hip bone, we had the obturator foramen, that big hole that was on the bone, in the bone. The obturator nerve runs through the obturator foramen. Go figure, there's holes in the bones for things like vessels and nerves to run through. Anyway, so this is the lumbar plexus, and this is it, shown again coming off the spine, as we know, and then that is the obturator foramen, as you know, and then they're going through and naming the ones, right? So iliohypogastric, so remember this is the ilium of the os coxa, and then ilioinguinal, so again the ilium of the os coxa, but coming os coxa, excuse me, but coming into the growing area, and then femoral, lateral femoral, so side thigh, obturator, anterior femoral, that one should be easier because it's the front of the thigh. So again, all you have to do is be able to recognize which plexus these nerves belong to when they are given to you. All of the following belong to this plexus except, or match the nerve to its correct plexus. So you don't have to know their names by themselves. You don't have to know their functions. You just have to recognize the plexus to which they belong. All right, so now we're on the sacral plexus, and I mentioned the sciatic one because I said sciatic already. What I will tell you is that men sometimes have damage to their sciatic nerve because they have wallets that are like very thick, and they keep them in their back pocket, and then when they are sitting down driving or whatever the case may be, their sciatic nerve is being compressed. That's a very common way that that it can be damaged. So sciatic nerve, is the common fibular and the tibial nerve, and I think I mentioned those as well, and other ones that are in this plexus. So again, we are looking at sacral, so the butt, right, the backside, superior gluteal, that should be easier, and there's an inferior gluteal, so a super butt and an inferior butt, and then of course you know that the common fibular and the tibial come together to become the sciatic nerve, so those are there, and then you have posterior femoral cutaneous. So posterior is the back, and then femoral is the thigh. So then you like sacral. So that should be, again, easy, right, to put these nerves in the correct plexus. Then I just show you a picture again, reminding you, of course, that they're coming off the spinal cord. You can't see it from this view, but they are coming off the spinal cord. And then if you look, this is the sciatic nerve. So the sciatic nerve, as I mentioned before, is the longest and the thickest nerve in the body. And that's because it's two nerves, the common fibular and the tibial nerve are part of that sciatic nerve. Now, I will tell you that if you've ever had Achilles tendon tear, so the Achilles tendon is the tendon that's attached to the calcaneus, which is the heel bone, and your calf muscle. So when you tear that, it's the largest tendon in the body. You guys know the story of Achilles, right? Achilles heel. Oh, he's my Achilles heel. That's my weakness. Anyway, it's been described that if you tear your Achilles tendon, it feels like you've been shot. And I remember hearing that description thinking, how would I know how that feels since I've never been shot? So when I tore my Achilles tendon, I was like, oh my God, I've been shot. I was playing tennis with my best friend, and I just pop, and I was hit the ground. I'm like, oh my God. Anyway, I knew immediately what it was, which is unfortunate. I didn't cry. I just felt a great deal of pain. I started crying when I started thinking about what I couldn't do. But anyway, the reason why I bring up the Achilles tendon is that the repair for the Achilles tendon is so extensive that they give you a nerve block. And when they give you a nerve block, they deaden this entire nerve plexus, right? The one that goes all down your leg. And so you don't feel your entire leg anywhere. Then when the nerve block wears off, a whole crap ton of pain comes rushing in at one time. Well, when I woke up from my surgery, you know how you're loopy coming off your anesthesia, but I woke up from my surgery and it just felt so weird to be disconnected from my leg. So remember, skeletal muscle is conscious control. So you look at your leg and you say, move, right? You don't even have to say it, right? You want to move your leg, you move it. You look at your toes and you want to wiggle them, you just wiggle them because you want to do it. So I'm loopy, and I wake up and I'm like, I can't feel my leg. And then I'm trying to wiggle my toe. I can't wiggle my toes. And so everyone's laughing at me, you know, my husband. And it's like, you know, Myria, they, deadened your leg, because he doesn't know the terms, but he's like, they deadened your whole leg. And I was like, oh, okay. And then I was like touching my leg and I couldn't feel anything. And then me being me, once the anesthesia wore off a little bit more, I still couldn't feel my leg because the nerve block hasn't worn off yet. But I punched myself as hard as I could in my thigh. I do want you to understand this, that we have a natural reflex to withdraw from pain, right? But I don't feel anything. So most of the time, if you try to punch yourself really hard, you're always going to give way because you're expecting the pain. And so my leg was dead, hauled off and punched myself in the leg as hard as I could. Didn't feel a thing, but left myself a nice bruise. So the next couple of days, it bruised quite well. And then when the nerve block wore off, my bruise hurt too. What was I thinking? All right. This is a cadaver where the sacral plexus has been dissected out. These are, and I'm just going to take it, these would be butt muscles. So you see I have the gluteus maximus here. So this, of course, is the plexus. And then look how thick this one is here. So you know that this is the sciatic, because this is the thickest, again, and the longest nerve in the body. All right, so let's see some things that would happen when you have damage to nerves in this area. So symptoms would be pain and numbness of the anterior thigh. The femoral nerve serves the prime movers that flex the hip and the knee. So if you damage that, you basically are just going to have a really hard time trying to walk. So if the obturator nerve is impaired, a person experiences pain in their medial thigh. You could have a herniated disc. You guys have probably heard of that herniated disc. Sometimes they happen because of car accidents or other things. Sciatica, again, very common. That stabbing pain over the entire course of the sciatic nerve. It could be, again, because you herniated your disc in that area, or you could have gotten an injection that was misplaced, right? So it went into the nerve instead of, into the muscle that's there, because a lot of people, as you guys know, get shots in the butt. And then let's see what else is there. I think it doesn't say it here, but I mentioned, of course, that men who carry or keep their wallets in their back pocket and then, sit could be compressing the sciatic nerve. If it's transected, which means like cut across, right? The leg is nearly useless in general because, again, sciatic nerves serves the common fibular and the tibial nerve. So basically hamstrings are paralyzed. And how do you walk? Hamstrings and quads are, of course, antagonistic muscles to each other. All right, so now we've gone through the plexuses: cervical plexus, brachial plexus, the lumbar plexus, and then the sacral plexus. Now we're looking at the thoracic region, where there is no plexus, but there are some muscles that need to be innervated. So like I said, intercostal are the muscles in between the ribs, right? Because costal means ribs. And so basically we have these ventral rami, and they supply, of course, the ribs, anterior lateral thorax, and those abdominal muscles. Again, abdominal muscles are also very thin, that are there as well. And of course, this is in this region. I do apologize. This is not supposed to say T12 to T12, because that would be like just one place. This is supposed to say T2 to T12. So I do apologize. T2 to T12. Make sure you change that in your notes so that when you go back and review them, it doesn't seem confusing to you. And I will change them and then re-upload the PowerPoint. So T2 to T12, okay? This is that, again, thoracic region where there's no plexus. There's no plexus, there's no plexus, there's no plexus, there is no thoracic plexus. All right, so now we have, again, those back muscles. So the back is innervated by dorsal rami, right? That makes sense, the little branches. We saw those in the picture where I showed you the back muscles. So rami are pretty short, but look where they're going. They're going right from the spinal cord to the muscles that are at the back. So they're very short, right? Very short distances there. Dermatomes are cool to me because dermatomes are overlapping and they cover the skin. So when I want to administer a local anesthetic to the skin, because maybe I'm going to do something like a lumbar puncture. As you guys remember, lumbar punctures would be for us to do a spinal tap so that we could test cerebral spinal fluid, for bacteria or fungi or whatever. Anyway, so if I wanted to cause the paralysis or the numbing of L4, I would have to make sure that I numb 3 consecutive dermatomes. So if I'm trying to numb L4, I'd also have to numb L3 and L5 because they overlap. And so L3, L4, L5, and then I could do the lumbar puncture at L4. All right, so this is, again, just kind of showing you the dermatomes and how they, are on the body. And so this is me saying, like, if I were going to do L4, which is here, then I'd have to do L3, L4, and L5 in order to get all of those, in order to get L4 to be completely numbed. All right, so let's get this straight. The effectors of the nervous system happen to be skeletal muscle, smooth muscle, cardiac muscle, and glands. And skeletal muscle requires nerve stimulus, so innervation. And then Hilton got a law for this. So Hilton got a law for this, and he got the hotels. Like, how fair is that? Hilton. Okay, anyway. So Hilton's law says basically if I innervate a muscle, right, and it's at a joint, then the skin at the joint, as well as the joint itself, will also be innervated. So at a joint. The skin is going to be innervated, and then the joint itself is going to be innervated. Why? Because muscles move, and that's all it says. It innervates the joint and the skin that's over the joint. A law. He got a law for that. Hilton's law. Still trying to find something to name after me. All right, so what do we know about motor activity? Well, we know the peripheral nervous system is sensory input. So sensory, and then afferent. I always think of afferent like affection, right? So sensation and ascending. And then motor, of course, is going to be the descending or the efferent, going to the effectors. So when we look at the motor endings of the peripheral nervous system, look at what it says. We release neurotransmitters? What? What? Are you kidding me? Seems like this would be a great opportunity for me to mention and emphasize to you again that there's no way to get around muscle contraction. Why? Because, as I mentioned, the effectors of the nervous system are skeletal muscle, smooth muscle, cardiac muscle, and glands. And I know you're saying it with me because I've repeated it so many times that it has been moved to your long-term memory banks. Anyway, so it says, oh, look, these elements are going to innervate your skeletal muscle and your viscera, internal organs, and your glands. What? By releasing neurotransmitters? And then maybe the neurotransmitter binds to its receptor. And when it binds to its receptor, maybe it causes ion channels to open. And then when ion channels open, sodium goes in and potassium goes out. And I get a localized change in charge, an end plate potential that then opens up adjacent voltage-gated ion channels, initiates an action potential. Then the action potential propagates down into the T-tube, which is causing the release of calcium. Calcium binds to the troponin, and troponin causes tropomyosin complex to open, revealing the active sites on actin so the heads of myosin can react with them. Yes, that. I'm back. Okay. Now, I want to be honest with you. This next test, right, the previous test had bonus questions that were associated with muscle contraction. We can't get around it. This next test, which is going to be peripheral nervous system part 2, then it's going to be the PNS, and then it's going to be the special senses. But right now, we are literally about to talk about muscle contraction, which means the bonus is not going to be muscle contraction, but muscle contraction can be on the test. Watch. Neuromuscular junction is where we're going to have the release of acetylcholine. What? No way. Acetylcholine binds to its receptors, resulting in the movement of sodium and potassium across the membrane. That causes a depolarization of the muscle cell. That end plate potential then spreads, then spreads to adjacent areas on the sarcolemma, the surface of the muscle cell, and then triggers the opening of additional sodium ion channels, right? And those sodium, of course, are voltage-gated ion channels. You know, the ones that don't open, won't open unless there's been a change in charge. Then we get an action potential, which leads to muscle contraction. Hey, I told you. So muscle contraction is back. It's back. Okay. So this picture looks extremely familiar. It's everything that I just mentioned. It's everything that we've gone over several times already, but we can't get away from it, right? Because the effectors of the nervous system are skeletal muscle, smooth muscle, cardiac muscle, and glands. Then we, of course, have, again, talked about this in the muscle lecture, but we can innervate our viscera. So viscera can receive impulses, not all of them, right? So some smooth muscle is self-excitatory, but smooth muscle that receives innervation happens to take place at the varicosities, because the varicosities is where we got the release of the neurotransmitters. Now, they do mention acetylcholine and norepinephrine. If you guys recall, norepinephrine is noradrenaline, and they tend to act indirectly through second messenger systems. And viscera motor, so the movement of your internal organs, is slower, right? It's slow ATPases than skeletal muscle, so it doesn't fatigue as much. And that's all the bottom line says down there is visceromotor responses are slower than somatic. Somatic was your body, your soma, which is skeletal muscle. But we know that skeletal muscle can fatigue easily, right? Because it contracts faster. And then I just show you some smooth muscle. We know that it's smooth muscle, one, because it says it up at the top. But if you look at it, we have these tapered cells that have one nucleus. So this is a smooth muscle cell, and we've seen those in the lab. All right, so when we look at the levels of motor control, this again is not going to be any surprise, I promise you. Segmental projection and pre-command level. I want you to know that the pre-command level is in the brain, and you shouldn't be surprised that we're going to be talking about the cerebellum, because the cerebellum, as we learned in central nervous system, is motor control. So the segmental level happens to be at the spinal cord. The projection level is the intermediate level, and then the pre-command level is in the cerebellum. Now, in the cerebellum, which is motor, basal nuclei is also mentioned there. And that's because, if you recall, and I hope you did, the basal nuclei helps us filter out antagonistic movement, unwanted movement, or unnecessary movement. Damage to the basal nuclei led to things like the flapping that was associated with Huntington's disease, or the shaking that was considered, that's associated with Parkinson's disease, right? So basal nuclei. So all you need to know about the segmental projection and pre-command level of motor control is exactly what I told you. The pre-command level is in the cerebellum, and the projection level is the pathway going through, right? Going up towards, and then the segmental is the lowest, so that's the spinal cord. And that's all it says here. Spinal cord is the lowest level. The projection level here is in the middle, so it's relaying the information back and forth. And then the pre-command level is the cerebellum and the basal nuclei. So make sure you know that. And then they just tell you, some more specificities, but I don't need you to know all that from me right now. All right. Jen, just to reiterate some things that we learned from CNS, is that now we're talking about the cerebellum, which is the pre-command level for motor control. Makes sense, because the cerebellum has motor control. And I know, I say this all the time, cerebellum always fusses at me because I say motor, 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 and the cerebellum, which of course I personify everything, says, I'm more than just muscle, Myria. And we know this because, again, neuroimaging shows us that when you are thinking, the cerebellum lights up. When you're going through emotional responses, the cerebellum lights up. So we know that there's more than just motor or muscle. Okay, all right. But look at what it says. Neurons in the cerebellum and the basal nuclei, again, we're talking about motor control, regulate motor activity, precise stopping and starting of movement, coordinates your movement associated with your posture, like, sitting upright, blocks unwanted movement. Again, that's the basal nuclei part of it. Monitor muscle tone. So remember, muscle tone is the ability for the muscles to be in a slightly contracted state to prepare themselves to be ready when we get ready to use them. And then perform unconscious planning and discharge in advance of the willed muscle. So willed muscle, of course, is what you control. And then the unconscious planning of those events, all of that's motor. And then the cerebellum acts on motor pathways through projection areas, acts on the motor cortex through the thalamus. And we know that nothing gets to the cortex except having passed through the thalamus first. So the thalamus is processing the information on the way to the motor cortex, which is part of the cerebrum. And then, of course, we know basal nuclei, like I said, inhibits various motor centers under resting conditions, because when you're resting, you don't want your muscles to be moving. So inhibits unwanted, unnecessary, or antagonistic muscle movement. And then they just kind of show you the pre-command, the projection is in between. Segmental is the lowest level, and that's what you have to know. Segmental level is the spinal cord. The projection level is, taking the information on its way up to the cerebellum. Cerebellum and the basal nuclei of the cerebellum are the pre-command. So this is pre-command and basal. Of course, don't forget that this is the cerebellum here, but then we have the motor cortex, which is located in this region. So remember it's the great region, but the motor cortex is precentral gyrus and postcentral gyrus. All right, so reflexes. Reflex is a predicted response. So it's a predicted response to a stimulus, but it's involuntary and it's rapid. So rapid, involuntary, predictable response. We test reflexes, right, to make sure that everything is working the way it should be. So we apply a stimulus, like with the patellar knee jerking reflex. The patellar tendon is struck with the little rubber mallet, and then you get a knee jerk. So knee jerk reflex, okay? We can learn or acquire reflexes from practice or repetition, like your driving skills. I know there's been times that you have driven yourself home from a long day of work and or school, and motor memory just got you there. You just got home. All right. So when we look at the reflex arc, this is going to be extremely familiar. So I have a receptor that's going to receive the stimulus. Then I have sensory neurons going to travel up. And then I have the integration where the brain determines what it is. Then it's going to go down motor neurons, and then it's going to go to the effectors. And effectors are and always will be skeletal muscle, smooth muscle, cardiac muscle, and glands. And so this is very similar, right? This is the whole nervous system, which I wrapped up for you when we first started with 3 phrases: sensory input, right? Integration, and then a motor output. So you shouldn't be surprised about anything that's there. Then again, terminology. We know that soma is the body. So whenever we see somatic, we're thinking of skeletal muscle. And we know that viscera is our internal organ. So that's autonomic. An autonomic nervous system is automatic, right? Automatic. So again, here are the reflexors. Here are the effectors listed. So I have my skeletal muscle, and I have my smooth muscle, and I have my cardiac muscle, and I have my glands. When we get to the autonomic nervous system, which is next, that's when we're going to talk about smooth muscle, cardiac muscle, and glands. But somatic nervous system is skeletal. So they're just showing you the reflex arc and the 5 components. So receptors, where the stimulus is applied; sensory is the way it's traveling afferently, right? Integration, understood, and then motor, traveling back down to the effector, and in this case, the effector skeletal muscle. All right, so spinal reflexes. These are kind of cool because you have a stretch reflex and a flexor reflex and superficial reflexes. But basically, if reflexes don't work the way they're supposed to, something is absolutely wrong. So you could have, it could be indicative of damage to your cortical spinal tract. So let's break down that word. Cortical, like cortex, and spinal, like your spinal cord. So you guys, if you remember properly, I told you that the pyramids, which are responsible for direct motor control, pyramidal tracts can also be called cortical spinal tracts. So the pyramids along the medulla that are for direct motor control could be damaged if we don't get the predicted response when we apply a stimulus. So again, a reflex is predicted. We know exactly what we're supposed to see. It's involuntary, which means you don't control it. It just happens. And it's rapid. So it happens very quickly. So what happens is that if you have an exaggerated response, or you have a distorted response, or there is no response when we apply the stimulus, then it's an indication that something is wrong. All right, so let's see. We have a stretch and tendon reflexes, and so stretched, because we know muscles do stretch, and then tendons. So this is information that we receive from the proprioceptors, and again, those are like the tendons and the ligaments at joints. But the length of the muscle is going to be determined, like the brain is going to know if your muscle's been stretched or not, and then the amount of tension on that muscle. Now, the length of the muscle has to do with information that's received from the muscle spindles. What I need you to know about muscle spindles is that they're intramuscular. So that means that they're like within the muscle. They themselves do not have contractile proteins like actin and myosin, but they're at the will, or at the mercy of skeletal muscle when it contracts. For example, think of like a slinky, and think of like stretching a slinky, and then think of a slinky that is, like compressed. So what happens is that we're talking about a stretch reflex. So when a muscle spindle is stretched, it's because the muscle has been elongated, right? So when I lengthen the muscle, I put tension on the muscle spindle. It's stretched, and that information travels to the brain and says your muscle is being stretched. Okay, so stretch reflexes. When there is no tension on the muscle spindle, it's because the muscle that the muscle spindle is a part of, the muscle itself, is contracted. So then the muscle spindle is loose and lax. And when it's loose and lax, there are no action potentials being sent. And so the brain says, oh, the muscle is relaxed because I don't feel the action potentials coming from it being stretched or having tension put on it. And that's basically all I need you to know about the muscle spindles. I'm going to show them to you in pictures, and it will make more sense. I hope it made sense the way I explained it, but it'll make more sense with the pictures. So they go through and they tell you about the functional anatomy of the muscle spindle, right? And that's great. Do recall, as I mentioned before, that there's no actin and no myosin. So muscle spindles themselves lack contractile proteins. And we also have some alpha and beta or alpha and gamma, and don't worry about that. But here's what the muscle spindle looks like. So the muscle spindle is this blue stuff, okay? So these are the blue stuff. And this is what I want to show you about how information about the length of the muscles being sent to the brain, whether or not it's being stretched. So they tell you how they're excited, blah, blah, etc. I like this picture. So see here where it says that when there's an unstretched muscle, that there are action potentials that are generated, but they're at a constant rate. So we realize that there is, the muscle's not contracted, but it's not stretched yet. When the muscle becomes stretched, action potentials increase. So rapidly being sent to the brain, and the brain's saying, oh, well, the muscle must be stretched because I'm receiving these action potentials really fast. Then when the muscle is contracted, so when it's contracted, the muscle spindles become loose and lax, no tension put on them. And when there's no tension put on them, there's no action potentials that are being fired. And therefore the brain, again, is aware of the state of the muscle. So that's all I need you to know about that, is that when there's tension that's put on the muscle spindle because the muscle's been stretched, action potentials rapidly fire to the brain, and the brain is aware that the muscle's being stretched. When the muscle is contracted, the muscle spindles, again, are loose and lax. Loose and lax, no action potentials are being sent. And again, that makes the brain aware of the state of the muscle. The stretch reflex, so the knee jerk, I mentioned that one already, where you tap the patellar tendon and get the knee jerk. Things that you need to know and understand is that we have antagonistic muscle groups. So the biceps and the triceps would be an example of antagonistic muscle groups. The biceps, of course, being here, triceps being here. If I contract my bicep, then I've relaxed my tricep. And if I contract my tricep, then I've relaxed my bicep, because they're antagonistic muscles. The same thing with the quadriceps and your hamstrings. So like if you realize or remember, quadriceps are the muscles in your anterior thigh, and then your hamstrings are the muscles in your posterior thigh, and they're antagonistic. If I contract my hamstrings, then I've relaxed my quadriceps, and then vice versa. And quadriceps are called quadriceps because there's 4 muscle groups that make the quads. What? No way. All right. Anyway, so the stretch reflex, activating the muscle spindle. So we said that part already. Okay. So there's a reciprocal inhibition. And that's because antagonistic muscles, right? So if I'm contracting one, then I have to rest the other. And all it says in the patellar reflex, the stretch muscle, which is the quadriceps, actually is going to contract, and the antagonistic muscle, which are the hamstrings, are going to relax. So make sure you understand how antagonistic muscle groups work. All right, so just some terminology to refresh your memories. So if it's ipsilateral, that means that the part of the brain controls that same side of the body. So right side of the brain, right side of the body. Contralateral was what we saw in the cerebral hemispheres. Ipsilateral is what we see in the cerebellum. Monosynaptic means that it synapses just one time. If something's polysynaptic, that means many things, right, came together, but monosynaptic. So it says all of the stretch reflexes are monosynaptic and ipsilateral. So same side of the body as the same side of the brain, okay? Stretch reflexes. So again, remember I told you that if there is, if we don't get the predicted response, there's going to be a problem. And it's indicative of some type of cortical spinal problem. So basically it says that stretch reflexes can be hypoactive. That means we didn't get the desired response. It was less than what we anticipated, because remember it's predicted. Or if it's absent, it could be that there's damage to the ventral horn. And this should make sense to you because the dorsal horn was sensory and the visceral horn is motor, and reflexes is are predicted responses, motor responses. So reflexes are absent in people who have chronic diabetes mellitus or neural syphilis, and they're also absent during a coma, right? So you are in a state of unconsciousness. Let's see, stretch reflexes can be hyperactive if you have lesions on the cortical spinal tract. So again, remember, cortical spinal tract is pyramidal. It reduces inhibitory effect that you would see, and as a result of that, you have a hyper or an exaggerated response. And then it just shows you again how the information travels. And so the muscle spindle, as I mentioned before, does not have contractile protein, so no actin and myosin, but it's in a muscle that is controlled by actin and myosin. So it's at the will of the muscle. If I put stress or tension on the spindle, it's because the muscle is stretched, and that increases the action potentials, and the brain says the muscle stretch. If you are in a non-contracted state and a non-stretched state, there are action potentials that are sent at a common rate, so the brain also knows the muscle's not stretched. And then if the muscle is contracted, right, if it's shortened, because that's what contractions are, then the muscle spindle is going to be loose and lax, no action potentials. And so again, the brain is aware that it's not stretched either. And then this is just the stretch reflex showing the patellar tendon. Apply the little rubber mallet here, little rubber mallet to the patellar tendon. You know, your patella is your kneecap. And you get this knee-jerk response here. We also know that we have the quadriceps, which are going to contract, and the hamstrings, which are going to relax because they are antagonistic muscles. All right. You don't have to know this or understand any part of this, but it's kind of cool. So remember I told you there's like alpha and gamma muscle spindles and their sensitivity. So if gamma neurons are inhibited, the muscle spindle becomes non-responsive and the muscle relaxes. And this is important for speed and difficulty increases. Important as speed and difficulty increases. So a gymnast that's performing on a balance beam, so they adjust, the muscle spindles adjust to the tensions and things that are put on them. So if you guys recall, we talked about how the muscles become stronger because of the stresses and tension that are put on them. Well, muscle spindles also react and respond with them as well. So the tendon reflex is polysynaptic versus monosynaptic. It helps prevent overstretching because overstretching could damage your muscles. So you've probably heard someone say, oh, I pulled the muscle in my leg, so I pulled my hamstring. When you say you pulled your hamstring, what it means is it's stretched beyond the point it should have. The only thing that you can do when you pulled your muscle, it's 9:15. The only thing that you can do when you've pulled your muscle is you can relax it so that it goes back to its normal resting length. If you try to work it too much, you just do more damage. So relaxation. So the tendon reflex is to prevent excessive stretching. So the tendon reflex produces muscle relaxation, so lengthening in response to that tension. There's a reciprocal action that takes place here. So it says the contracting muscle will relax and antagonistic muscle will then contract. So that's that reciprocity. Information is transmitted simultaneously to the cerebellum, which you guys know is for your motor control, and then it makes the necessary adjustment on the muscle tension. So again, it's to protect, right, muscles from being overstretched. So that's what the tendon reflex is for. Let's see, the flexor reflex. I like that, flexor reflex. This is our natural, because it's a reflex, our natural ability to withdraw from something that we perceive to be painful. So if you've ever given blood, like back in the day, they would do a needle stick. I hate the needle stick, but people see the needle coming and, you know, they have a, you know, a tendency to want to, like, you know, move away from it because it's the withdrawal reflex or the flexor reflex. But we can override that. So I know that it's going to hurt, but I want to give blood and I got to test my hemoglobin. So I let them stick me and I consciously, right, control. So I override the reflexive ability to want to move it. But there are people who are really afraid of needles. And oh my goodness, you have to have them look away. You have to have nurses, you know, hold down their, you know, arm or leg, because you could actually do more damage when we're putting a needle or trying to put a needle in your arm, more damage with a person, you know, trying to resist. So it's protective. So the flexor is protective. So it says that the stimulus is something that's painful or perceived as painful. So all that means is, and I tell this story all the time. So the peanut butter jar, I hit the peanut butter jar. We use plastic ones, not glass, but hit the peanut butter jar and it rolled off the table. And I just took my, foot and I go, ah! So I lifted my foot and went, ah! And my husband's like, what happened? I was like, the peanut butter jar fell off the counter. And he's like, did it hit you? And I was like, no. He's like, what'd you scream for? I'm like, because if it hadn't hit me, it'd hurt, right? Like if it had fell on my foot, it would hurt. So I immediately moved my foot out of the way and said, ah, all at the same time. Anyway, so when we look at the flexor reflex, it is ipsilateral. So again, same side, right? And it's polysynaptic. So many synapses, protective for survival. So that's a big deal. Again, protecting yourself against something that's painful. And like I said, the brain can override it. The cross tensor reflex occurs when the flexor reflexes in weight-bearing legs to help us keep our balance. So if you've ever in your life lost your balance, you know that when we compensate, you see people like, that they trip over something and they're just waving and flapping and eventually fall. So what happens is that when you are off balance, you immediately shift to the opposite body size or the opposite side of the body, trying to counteract the imbalance. So if you're falling to your left, you shift to your right to try to compensate. It's like if you were driving, and this happened once in my lifetime, but if you were driving and you fell asleep at the wheel and you woke up and you were like going to the right, what you did immediately, right, if you're going off the road to the right, is you took the steering wheel and you jerked it in the opposite direction, right? So that's that counterbalance there. So that's cross extensor reflex, helps us keep our balance. If you step on a piece of glass, right? You step on the piece of glass, what you immediately do is you withdraw your foot, right? Because it's a painful stimulus. Very last thing you want to do is lose your balance and fall back on that piece of glass. So you shift to the opposite side to help counteract the balance. And that's all it says. At the bottom there for the examples, stepping barefoot on broken glass causes the damaged leg to withdraw and the opposite leg to extend to help support the weight shift. And then if you grab someone's arm, this is kind of cool, someone's arm, you cause that arm to flex, right? So you grab that arm, you cause it to flex, which causes the opposite arm to extend. So opposite, right? You're trying to counteract in this case, the stimulus. So if you ever did sports when you were in high school or college and you had to get your little, oh my gosh, what is it? Physical. I like lost the word. So you went and get your little physical and they did the patellar tendon reflex, because that's important. Remember, I told you if there's damage to that, that's an indication that there's damage to the corticospinal tract, and you probably shouldn't be doing sports. But you also were told to put your arms out like this, and what the doctor did is pushed on your arms and told you to push against them, and then went underneath the bottom here and pushed up and told you to push down. They're actually testing your cross extensor reflexes. I know, it's like a all right, so there's some other superficial reflexes, the plantar reflex and the abdominal reflex. If you try to elicit the abdominal reflex on me, you get a punch. That's my reflexive action to that, because I don't like to be tickled. The plantar reflex is on the foot. And so I've got my 7-month-old granddaughter, and I do the little reflex things on her all the time. So when she's little, I used to do the rooting reflex here where she starts to suckle. So she thinks that she's about to nurse, I know, but this gets her rooting, so suckling. And then the plantar reflex is, you have to pretend that my hand is my foot, but the plantar reflex is when you stroke the lateral aspect of the foot and then your toes curl. That's what you see in babies that are greater than a year of age, and then adults. You see the curling of the toes. We call it dorsal flexion. If you see in a baby, we have what we call the Babinski. So you stroke the lateral aspect of the baby's foot, and the toes go back and fan out. So toe curling for adults, and then and that's the plantar reflex, and then babies is the Babinski reflex. Their toes kind of fan out, and there's dorsal flexion, so the big toe like goes backwards. It's kind of cool. Anyway, so that's all it says here. Stroke the lateral aspect of the foot. Babinski is the dorsal flexion of the hallux, which is the big toe, and then the toes fan out. This is usually what happens when they're less than a year of age. If there's damage to the motor cortex in adult and we see the Babinski sign, then we see the Babinski sign if there's corticospinal damage in an adult, because what we should see is a downward flexion, so toe curling. And let's see, so toe curl. Okay, and then abdominal reflexes. You can do this with anyone, but not me, because I'll punch you. So when you tickle someone, right, when you stroke their stomach, so it says stroking the skin on the lateral abdominal region, above, below, or on the side of the umbilicus. So tickling someone causes your muscles to contract. It is a reflex. So contraction of the abdominal muscles and the movement of the umbilicus towards the stimulus varies in intensity from one person to another, but that's what happens when you tickle someone. They contract their abdominal muscles. It's a reflex. It's absent though with people who have lesions on the cortical spinal tract. Okay, so that is the end of the lecture. Not too terrible, just a few minutes later. So that is the end of the lecture. I'm going to stop the lecture recording.